Okay, so now let's talk about something very interesting. Here you can see that we have an athlete named Daniel, and he is a runner and a marathoner, and he has got severe bruises due to running. But is that the usual thing that happens? Now let's see more deeply. So basically, Daniel is a 38-year-old male marathon runner, software engineer, and he has explained fatigue and unexplained bruising and persistent low-grade fever for the past 2 weeks. The history of presenting illness was that he, despite of being a long-distance runner, noticed increasing exhaustion during his morning runs. He attributed it to overtraining, but when petechiae appeared on his lower legs and gums started bleeding spontaneously, he consulted his primary care physician. And he also noted that he had lost 5 kg weight over the past month, and there were also night sweats and frequent nosebleeds. And then the vitals were normal, but the BP was a little bit low, but it was somehow normal. And in the skin, we noticed petechiae over the lower limbs and ecchymosis, which are larger red spots on the arms, and they're like bruises. Petechiae are smaller. And he had pale conjunctiva and bleeding gums. Bleeding gums is very important in this. And there was also noticed mild cervical lymph adenopathy, and he had mild splenomegaly. This is the point, guys. And then there were no focal deficits or cognition defect over there. And for the lab investigation, WBCs were dangerously elevated. This indicates leukocytosis. And HB was very low. Here you can see it is only 7.8. And platelets were very low as well. So they're only 22,000, where the normal range is 150,000 to 450,000. LDH was also raised, okay? So this is an important pointer. And 860 was the reported LDH. However, the normal is 142, 280 U per L. Peripheral smear showed us blasts with Auer rods. So for this is a very, very important indicator, because when Auer rods appear, we are basically on M2 stage of the AML. And bone marrow biopsy showed more than 30% of the myeloblasts. And flow cytometry showed CD13 plus and CD33 plus marker. These are very important for M2. And cytogenetics showed translocation of 821 and RUNX1. Molecular testing showed FLT3 negative and NPM1 positive. So diagnosis was AML M2 stage. Treatment plan is 7+3 regimen and supportive care, including platelet transfusions, antibiotic therapy for neutropenic fever, allopurinol for tumor lysis prevention, and post-remission therapy is high-dose cytarabine consolidation.